Hi there, and welcome to this episode of the Guns Magazine podcast. I'm your host and the editor of Guns Magazine, Brent Wheat. Thanks for joining us here on one of the world's biggest gun talk programs as we chat with the interesting folks who make up the world of shooting. Well, my guest today is Will Dabbs, MD. Most folks know him as a gun writer, but in his day job, he's a medical doctor. And as a medical doctor, he's dealt with something called exsanguination. That's the fancy medical term for bleeding out, and that's the number one cause of death for folks that suffer gunshots. Also for people that are suffering chainsaw wounds or machinery injuries or even large toothy animals. So I thought this would be a good time to chat with Will, since he actually knows what he's talking about. And we're going to talk about stopping the bleed, tactical tourniquets, direct pressure, and our thoughts on how you deal with all this stuff. So before we get started, quick housekeeping note, please make sure you like and subscribe. We say that all the time, but that's the number one way you can support what we're doing and keep great content coming. Also, before we talk to Will, here's a word from our great sponsor, Armasight. Step up your game with Armasight's cutting-edge thermal and night vision monoculars. Built for hunters, tactical pros, and outdoor enthusiasts who demand clarity and reliability in any environment. Discover the performance and durability trusted by hunters and professionals worldwide. Gear up now at Armasight.com. Stop looking, start seeing. Well, hello there, Dr. Dabbs.
Hey, brother.
How are you today?
I'm thriving. I very much appreciate you having me as usual.
Well, of course. We love having you on. The audience loves having you on. And I even dressed up today. How about that?
On that subject, as I was coming down here to set this up, my precious wife looked up from her moldy old English literature and said, your shirts don't match. And now, firstly, matching colors is a girl thing. Guys can't comprehend any of that. And I just told her, I'm a gun writer. They're fortunate I'm wearing pants. So
exactly.
Just be thankful.
Well, and Roy calls it your spaghetti shirt because, sometimes you see guys that will come up to you at events like the SHOT Show and they'll have a big blob of spaghetti and a shirt with a rip. And, hey, I'd like to write for you. Okay, well, you send me an email and we'll see if we can't get on that. So speaking of the SHOT Show, that perfect lead in right to what we're going to talk about today. You and I spent some time walking around the SHOT Show last month and it was great. It was a joy to watch you work. You're good at this gun writing and video thing. And so if you ever decide to have a third full-time career, I think we can find a place for you. But we were discussing we went by a display with tourniquets and we were talking about that. And I mentioned, and I had to bring this up, I went to the Gundy Awards and both Tom McHale and I got nominated. And of course, Masad Ayub won for Best 2A Communicator. So we're very honored by that. But I got to say, not my crowd, not kind of my circus, but I was really surprised to see a couple of guys in their formal wear with their cat tourniquet prominently displayed. And I thought, you are tactical, dude. You are uber tactical. So we're going to talk about that today. The technical term, as you told me, is exsanguination, which means bleeding out. And I'll shut up here in a minute, but I always remember what you tell me, and it's kind of a good life philosophy. All bleeding stops eventually. Now, it may not stop in the way you want it to, but you're right. It does eventually all
bleeding
stop.
stops.
Exactly. So anyway, kind of the goal here is we're going to talk about it. Tourniquets are such a hot topic among the super uber tactical community, but they do serve a pretty important function. And I got to say, at the end of my cop career, they were just kind of becoming a thing. So I'll be the first to say right now, I've seen tourniquets applied. I've held direct pressure on gunshot wounds, knife wounds, but I've never personally cranked down a tourniquet. So I've been to a lot of training and I've got a bunch around here, but we're going to go beyond tourniquets even, hopefully, and just talk about a lot of our readers are out in the wood shop and they might manage to lop something off. So we're going to talk about both the tactical and the tourniquets and maybe just how you can stop the bleed, because that's the end result, right? So, okay, I talked a bunch. Your thoughts as we talk about exsanguination.
All right. Well, our conversation needs to be fairly dark, but let's just talk about how this might actually occur. So, what's the mechanism of death after a gunshot wound? If you've not disrupted the central nervous system, that it's almost always exsanguination. You almost always bleed out. And so, per our previous discussion, what I kind of thought we would talk about today, we'd start with sort of the anatomy and physiology of the circulatory system and how that relates to the armed professional. And then we would move on to some war stories. And then if we've got time, we'll talk about different types of tourniquets.
Sure. So those are operational briefs, those, Will.
No,
not war stories.
Okay. Yeah. Operations. Sorry. So here's kind of a one over the world on cardiac physiology as it applies to what we're talking about here. So your typical adult human carries about 5 liters of blood. And so a good way to visualize that is that's 2.5 2-liter Coke bottles. And 12-ounce Coke can is about 1/3 of a liter. So 3 Coke cans is a liter of blood. And so to put that in perspective, if you're starting to bleed, you lose 20% of your blood volume, about a liter. So half a 2-liter Coke bottle, 3 12-ounce Coke cans, and you'll lose consciousness. You make that 40%, so 1 2-liter Coke bottle or 6 cans of Coke full of blood, and that's lethal. And it's high volume cardiac failure. Your heart just doesn't have anything to pump. And so that's the mechanism of death under the circumstances of most gunshot wounds that don't disrupt the CNS. Now, that having been said, a 2-liter Coke bottle is a lot of blood. You can paint a room with that, except when you're that jazzed and your catecholamines are cruising and your heart's at bumping 150, 160, you can bleed out fast if you've got a decent hole. And so, as I said, what I thought we would start with is just some anatomy. So the way the heart and the circulatory system works, it's an amazing design, just like everything God makes. But your heart is 2 pumps that are hooked together. They share a common septum, and each pump has 2 chambers. So the atrium on the top and ventricles on the bottom. So the left heart goes to the body, the right heart goes to the lungs, and it's a figure 8. It's a closed circuit system. And so to kind of understand how this works, let's explore exactly what blood pressure means. So those 2 numbers, your amazing physical specimen like Tom McHale, and so your blood pressure probably lives about 120/80. Well, those units are millimeters of mercury. Just think about it like pounds per square inch. But you're not born knowing what those 2 numbers mean. And so folks ask me all the time, what's more important, the top one or the bottom one, in the context of trying to keep your blood pressure under control? And yes, they're both important. So basically, those 2 numbers, that bottom number is a baseline pressure all the time. So blood is a liquid, it's incompressible, it's just like hydraulic fluid in the brake system in your car. And the arteries go away from the heart, and they've got muscles in the walls. The veins come back from your toes, and they don't have muscles, so they're kind of floppy. But you've got this 5 liters of blood, and those arteries are squeezing them at all times. And so that's where that bottom number comes from. So with 80 millimeters of mercury, that's that bottom number all the time. And so if you were to plot your blood pressure out, it's 80, 80, 80, 80, 120. 80, 80, 80, 80, 120. And the 120 is the power stroke as your heart beats and pushes the blood all the way to your toes. And so, but that baseline pressure all the time is a function of muscles in the walls of the arteries that are squeezing that volume of blood all the while. And that's the reason when someone dies, they stop bleeding, because those muscles all relax. So that's kind of the nature of cardiac anatomy. You move vast quantities of blood. I should have looked it up, but I've forgotten. But vast quantities of blood every day. And that blood pressure is necessary to retain consciousness. So your whole body is designed basically, no matter the orientation, to keep that basic blood pressure the same in your brain, because if the blood pressure drops past a certain threshold, you lose consciousness. So the issue with gunshot wounds is you're interdicting that system and allowing that blood pressure to drop to the point at which you're no longer functional. And so basically, gunshot wounds in the real world, as one might anticipate, are just not much like the movies. And so I thought that we would discuss a handful of examples, at least one of which many of our viewers would probably be familiar with. There was a young ranger named Jamie Smith during the Battle of Mogadishu, and this circumstance was described in great detail in both the book and the movie, Black Hawk Down. But Ranger Smith was hit in the groin and severed his femoral artery on one side. And there was a really moving segment in both the movie and the book where they're trying to get control of that large caliber piece of plumbing to keep him from bleeding out. And the Delta medic is trying desperately to get on and get a hold of it. But one of the interesting things about blood that I didn't really appreciate till I started doing this for a living is completely opaque. Once you get a little bit in a wound, you can't see anything. And so in the field, if you've got, gauze sponges or you've got a t-shirt or something, you can mop it up. You can get little glimpses of what's going on. And, in the operating theater, you'd have a suction device. One of the biggest challenges in managing significant bleeding in the field or in a place where you don't have a lot of tools is you just can't visualize what's going on underneath all that. To the point at which, in many cases, it's relatively fruitless. But in the case of Jamie Smith, the stub of that femoral artery pulled up into his abdominal cavity, and he bled out, which was obviously fairly poignant and horrible. That's something that could have been managed in an operating theater, but they were under fire and couldn't medevac him. Now, you can bleed out. You can lose that 2 liters of blood with a shockingly little amount of external stigmata. I saw a guy in the emergency room in Jackson when I used to work there who was shot in the right chest with a 380, and he had the ball round. We identified it later on an x-ray, but it was shot in the right chest. The entrance wound was kind of midline between the sternum and the right nipple, and there was essentially no bleeding. It was just a little black hole, and there was no exit wound. And over the course of a very brief period of time, he exsanguinated into his chest. And towards the end, there was a lot of bleeding out his nose and mouth. But the surprising bit is that you can lose that 2 liters of blood without a whole lot of it coming out on the outside. I saw another very unfortunate gentleman who was was unrestrained in a car wreck, and so he slammed forward in the vehicle, what during World War II would have been called a Jeep driver's accident. Your knees hit the dashboard, and it creates what they call an open book fracture of the pelvis. And so the pelvis rolls back when the femurs are pushed back, and it'll tear the bridging veins in the pelvis. And this poor guy actually bled out into his scrotum. His as dark and horrible as this sounds, his nutsack was about the size of a soccer ball.
Oh my!
And his blood, he had been bleeding for a while before I met him in the ER, and there was just no time to fix it. But he exsanguinated with no blood at all on the outside. So it's not much like the movies.
Yeah, I was going to say my own operational debrief. We had a situation where a gentleman was stabbed, and we thought he was thrashing around and unresponsive because he was drunk. Well, he had alcohol on board, but it turns out he was doing exactly what you said. And when the surgeon got in the ER and put in a chest tube, by the time that was done, it looked like somebody had thrown a bucket of blood on the floor. It was spectacular. And that really shocked me, because I knew it was possible. I'd heard the stories, but seeing it right in front of my eyes, this guy, I don't remember seeing a drop of blood on the external wound, but it obviously nicked something very big on the inside, and that fella didn't make it.
Well, and your diaphragm is a very thin piece of muscle, but from there up, most of your chest cavity is just empty space. Your heart's about the size of your fist; it sits right here, but your lungs, there's a lot of room for mischief in there under the wrong circumstances. The story that you and I discussed at SHOT, I just will refer to as some idiot guy. If he's out there listening, let's just say it was a learning experience for all of us involved. And Brent, as we go along, obviously, if I need to shut up for time purposes, just tell me and I'll put a cork in it.
I love hearing the stories, so keep going.
Well, so I'm working in my urgent care clinic, and this guy comes in, and he's a construction worker. And so we're first come, first served. We're not an emergency room. So, if there's something that won't wait until you kind of have your turn, you need to go to the emergency room. And that's, amazingly, in my little clinic, I've seen gunshot wounds and snake bites and all kinds of things that people will come into the clinic just because they don't want to go to the hospital. But in this case, big old beefy ripped guy in his early 20s. He's got a big bandage on his right arm. And So he just says, I cut myself on the work site. And one of my nurses came and asked me to go look at it in the waiting room and see if it was something that would keep. And so I went out there. He looks fine. He's got his redneck buddy who's there with him. And I peeled the bandage back from the distal portion from the far end and looked, and he just had a little, about a 1 inch laceration in the antecubital fossa in the front part of his elbow, and it wasn't bleeding at all. And I said, sure, I can fix that with my eyes closed. That won't be a challenge. And so when they got him back into room 7, which is the playroom at the clinic, the procedure room, getting my gloves on, getting my stuff ready, and without my realizing it, this guy pulls out his pocket knife and he cuts this t-shirt off, and he'd had a bootlace tied around the top of his arm. And before I could say anything, he took his knife and he cut it. And blood came out of that guy's arm like it was a garden hose. I mean, it went all over the place. And then his stupid buddy starts laughing and he says, oh yeah, man, back at the work site, there's just blood all over the place. And there's blood standing in the pickup truck. And it's like, man, you didn't mention that.
Yeah.
But the mechanism of the injury, he was cutting a brick strap off of a cube of bricks. And when he snipped it with some, tin snips or whatever, it came back and just popped him in the arm. And what I didn't appreciate at the time is that it lacerated in a linear fashion the median cubital vein, which is the vein that you use to draw blood for the most part when a phlebotomist is going to draw blood. And so that thing just happened to hit him in such a way that it cut along the length of that vein. And so at the time, I keep a tourniquet in the treatment room now because of this experience, but I didn't then. And the only thing I had handy was a box of rubber gloves. So I grabbed a rubber glove and I put it around his upper arm, but he's a big ripped guy like you and me. And so he, as tight as I could, I put 2 of them up there and I made it as tight as I could without snapping it. And it still didn't compress the artery enough to slow the blood flow. And I realized at the time that the blood was not pulsatile. So the blood's coming from his fingers. It's not coming from his heart. And so I got my nurse to slip into some gloves and we both kind of jumped on it. And I tied a couple of tourniquets distally on his forearm, and that slowed it down enough to kind of get a feel for what was going on. As I said, blood is completely opaque. You can't see anything. And so I cleaned it up enough to kind of get the lay of the land and just grabbed some 4-0 Vicryl, some absorbable sutures. It's just the only thing I had. And I threw some deep sutures in there and thank the Lord didn't ligate his median nerve or something horrible. But eventually got it slowed down enough to where I could do a figure of 8 over the vessel and tie it off and then deal with it at my leisure. And it turned out fine. But as soon as he started bleeding, he lost consciousness. And so in the context of what we were just discussing, that's your first leader. So I realized I'm sitting in there in room 7 trying to get this guy to stop bleeding, and he's just lost 20% of his blood volume because he's this ripped 24-year-old guy who is now unconscious. Now that was handy because I didn't have to numb anything up. I could just work on his arm without his freaking out about it. All the while, his stupid buddy over there is just laughing, having no idea how serious this is.
Wow.
And it's interesting what goes through your mind from my perspective as a physician, because I'm sitting there thinking, I've seen a lot of bleeding, but I've never had anybody try to bleed out in the clinic. And, if he arrests and I start doing CPR on him, is that going to really help much if he has no blood volume? And the big hospital's 6 minutes up the road, but he's going to be long dead by the time I can get him up there.
Yeah.
But he was unconscious the whole time I got him fixed. And we eventually got he was so volume depleted, we couldn't start an IV afterwards. But over the course of a couple hours, we got him back and got him some Gatorade, and he went home. And when I saw him a week later to get his stitches out, it was like, dude, do you have any idea how close you came to dying in room 7 at the urgent care clinic in Oxford, Mississippi? But God smiled upon us yet again, and there was a happy ending, and he got to go home to his family. But that was one of the more exciting experiences I've had in my little urgent care clinic in Oxford.
Wow. Well, I'm going back to a couple of courses I've had, and I always remember one of my instructors, because I've been, again, I was a police officer for a long time. I went through first responder training a couple of times, and I was always a guy, I would get in there if there wasn't anything else going on and help as best I could, and I'd always help medics, paramedics. But when the tourniquet thing started happening, I said, okay, we've got our tourniquets. We've got all this high speed, low drag gear. When do you know to put it on? And his words were, when you look at it and go, oh my God. And I thought, okay, I guess that's pretty good. I said, that's not really quantifiable because your experience, if you see that much blood and you're like, oh my, yeah, slap a tourniquet on it. So,
well, and we put a lot of effort and thought and intellectual capital on tourniquets, and under certain circumstances, they are very, very important. But those are relatively narrow circumstances. So obviously, it's not going to help you with a head wound. It's not going to help you with a torso wound, and you've got to be able to get it arranged between the wound and the heart. And there are lots of different kinds. The two probably most popular ones are the rats and the cat. I don't remember rapid access tourniquet system and combat application tourniquet, if I remember correctly. But the rats is just a piece of almost like bungee cord that's got this little stamped aluminum cleat on it, and it's pretty stupid proof. I've played around with both of these. I can't say that I keep a rats hanging on the wall in the clinic now, but I've never actually used either of them. I've just seen this on the receiving end when they come in to the ER. But it works like a champ. And then, but it's basically you slide it over the affected limb and you tighten it down and wrap it around and then hook the tail end in the cleat. The cat tourniquet is a Velcro affair that goes around the limb, and it's got a windlass. And so you turn that thing and it tightens down. You just tighten it until the bleeding stops. But to be quite honest, for all the fancy schmancy stuff that goes into that, you can do the same thing with a bootlace. Just tie the bootlace proximal on the near end of the wound in a square knot, lay a stick over the top, try another square knot, and then twist it until the bleeding stops. But then what? Let's say it works. Well, you need to move with a purpose, and the published time frame is about 2 hours. But as a physician, it would terrify me to reperfuse a dead limb after 2 hours, just because of all the nasty inflammatory cytokines and such. There's you run the risk of compartment syndrome from the swelling. There are all kinds of bad things that can happen if you open up the plumbing, and then all that junk that's in that limb that's been denied blood supply for 2 hours is now going to your brain and your heart. But the published time frame is about 2 hours. That after that, you really run the risk of losing a limb.
Yeah. Well, one of the things that, and that was really kind of the genesis of our discussion in SHOT Show, was I've noticed through my life and adventures in doing this that tourniquets seem to be one of the most, I wouldn't say controversial, but there are a whole bunch of different kinds of them. And when I talk to my friends who are medics and, combat medics and all that, every one of them generally has one that they are convinced is the best thing ever. And they tend to feel like every other tourniquet on the market will kill you. And it's a very all or none binary A or B kind of thing. And that's interesting because, again, most of these guys got a lot of experience. But, I also go back to bootlaces have saved a lot of people's lives, and they've been doing this, since the Civil War or before. So your thoughts on getting the right, because I've got all of them. I favor the rat one. I've got it in my truck because I figure it's essentially a bungee cord, and I can figure that out, especially under the stress of somebody or me bleeding. But what's your thoughts on choosing the very best tourniquet?
That's a great question. And those guys that you're just talking about have a lot more experience with it than I do. And, once again, my experience with exsanguination is from the perspective of the guy at the other end of the ambulance when it arrives at the hospital. And, the concern as far as using a bootlace is a function of pressure because, in both cases, the bungee on the rat's tourniquet is probably about as big around as my finger, but then if it's appropriately applied, you end up wrapping it kind of sequentially, and so you spread that pressure out over a fairly significant area, and it minimizes the risk of actual tissue damage or crush injury. And then the cat's the same way. The thing is about that wide probably, and so as you're torquing it down, the pressure that you're putting on the wound on the limb is spread out enough to where ideally you're not going to further damage the limb. Where if you've got just a bootlace, that's obviously fairly sharp. But at the same time, if you're using a bootlace, it's because you don't have anything else. And the argument that they made when they were teaching me how to do all this stuff is, you do what you've got to do so that the guy will survive to get to the emergency room and ideally will go home to see his family, even if it is perhaps without an arm or a leg. But, practically speaking, you could improvise the same thing out of a t-shirt. It doesn't necessarily have to be something as sharp as a bootlace. But I can't say that I personally have a favorite. I likewise have a nice collection, and I keep the rat's tourniquet in the clinic simply because it hangs nicely from a nail. Because, I loop the thing back in on itself and just hang it there, and I can reach over and grab it quickly. The appeal of the cat tourniquet is that thing, in its stowed form is about this big, which is probably the one that your buddies at the Gundy's were. It just fits nicely on a belt or in a medical bag or something. It's easier to keep up with. But I can't say that I personally have a favorite.
Interesting story in that regard. When I was working the road, I always carried a SWAT tourniquet. They all have these great acronym names, and the SWAT tourniquet's pretty simple. It's pretty much an inner tube or a big rubber band, and it's obviously more than that, but that's essentially what it is. And I carried it A, as self-rescue, and B, for any of my guys. And I had a couple of medics like, "Oh, that's the worst tourniquet. You might as well not carry anything." And my answer to that, whether this is the right answer or not, is at least I can get something on them initially, quickly. And then if somebody else has got a higher speed, tourniquet or something better, great. But I know how to use this one because it's essentially a rubber band. And that was kind of my theory of get something done, kind of that something now is better than perfect later. And my fear has always been with the cat tourniquet. I've got practice ones. I've taken formal training in using one. If I'm confronted with my best shooting buddy has just blown part of his hand off and he's bleeding badly, it may be tough for me to go, okay, now this and insert that and turn. I know with a cat or a rat or a SWAT or one of those, I can figure that out. So that's kind of my theory of something now that works partway even is probably better than sitting there trying to read those instructions and, oh, wait, they're covered in blood. I can't remember how this thing works.
No, you're exactly right. And, you fall back to the basic common denominator as far as your training is concerned. And, probably been inundated with hate mail, but, the world is covered in a thin patina of gear bigots. And whether that's my rifle is better than your rifle or my Zev handgun shoots better than your Glock.
Yeah.
At the end of the day, carry what you can afford, but at the end of the day, get good at it. And, it's not hard to go to the local range and find somebody with a $3,000 tricked out SCAR 16 who can't figure out which end the bullets come out of. And then you've got some other redneck guy from around here who's been shooting since he's 3 years old, who has a $500 AR-15 and can run it like a Delta Force operator. So it's at the end of the day, anything you've got is better than nothing. And, I think back to, we had a woman code in the clinic a few years ago, and, all I had to do was use an AED, and that thing is designed to be stupid proof. So you just turn it on and do what it says. And if you have somebody who is in cardiac arrest, that thing will tell you to do CPR, will tell you to shock them and so forth. And I had to take a deep breath and think a little bit to get the stickers on just right. And, I kind of do that for a living. But at the end of the day, it's real easy to sit here in a climate-controlled environment talking to a dear friend about the nitinoids of exsanguination, but when it's particularly if it's bleeding arterially, I mean, I've seen some arterial bleeds that would go all the way across the room and across the ceiling.
Yep.
And that's just viscerally shocking. And
Yeah.
Under the best of circumstances, unless you're a trauma surgeon or an ER guy and you do that all the time, it takes a little personal discipline to keep your wits about you under those circumstances.
And I think, and that's something, you know, we're blessed here at Guns Magazine, and I'll say the same thing over at American Handgunner. We've got guys that have been there, done that. And it's like you said, it's easy to say, well, first you do this, then you assess. And it's like, it's a different deal when suddenly you're confronted by something. And as you said, blood is hitting the ceiling. That's always kind of our inside joke is there arterial bleeding? Is blood hitting the ceiling? No. Well, then it's not that big a deal. But we've seen that. And as you said, I don't care unless you're just the hardest of the hard or the experienced of the most experienced. There's always that moment where it's like, oh my, wow, okay, now I got to think, I got to do this and I got to do this. But for folks that have never confronted that, it's 10 times harder. So, you know, the best you can prepare yourself is great, but understand there's a lot of different names for it, but that reaction of, oh my gosh, what do I do? Because the first thing your brain tells you to do, panic. Okay, you got to panic. You got to scream and run around like a little girl. And the folks that deal with that kind of stuff regularly, I've told you, Will, I'm always amazed at the doctors at the ER, especially you get a doctor, say my age, that's still working the ER. You could bring in bits of guy in a Ziploc bag, and you go, okay, what do we got here? And it's that cool collectedness that it's pretty amazing to watch in progress. So. I guess what I'm saying here is realize the fog of war isn't just in shooting. It's in the aftermath of, and again, we keep talking about gunshot injuries. A lot of guys my age, we tend to run our hands through bandsaws or, you know, just broken glass. It happens. So that's kind of why I wanted to really bring this point up again, that be ready to stop bleeding because it happens.
Yeah, and you know what I found as a physician. Firstly, the reason those guys can do what you describe is the first day of gross anatomy. You walk into a room full of 25 dead people, and they're all on their backs. And so you've got the first day is the superficial muscles of the back. So you've got to grab your cadaver and roll them over. So from day one, you've got to put your hands on them, and that's a pretty unnatural act. But at the same time, you know, a week later, you could eat pizza in there. It just doesn't, you can acclimate to absolutely anything. But if there's a take-home point to our conversation here, you know, I'm not a trauma surgeon. My brother is, and he can do all kinds of things that I can't. But at the end of the day, the most important attribute under those circumstances is you don't want to be that guy that you just described. The one thing that does not help is if you're running around screaming. And so, what I found in medical training is there are a lot of times that your doctor doesn't know what to do and you are not aware of it. But they sort of train us to be that fixed point. And there were a lot of times when I was just kind of earning my spurs in the emergency room that something would roll in and I just would not have a clue. And I'm in a room full of 8 or 9 highly trained ER nurses and respiratory techs and so forth. And at the end of the day, you just can't freak out. You know, and you inculcate the ability to look at that horrifically gory, horrible, unimaginably unseeable thing, and then just, if nothing else, you know, if it's bleeding actively, put your hands on it. And that doesn't necessarily mean, you know, dive in and get it in your face, but grab a t-shirt, put it over the wound, get involved. Direct pressure is always the first step before you start worrying about tourniquets and all that. As a lot of these wounds look horrific, but if you just put some pressure on it, you can get it under control enough to at least catch your breath and think about what you're going to do later. And that's, you know, without talking about quick clot and all the other really very effective fancy smancy stuff that we've got now that we didn't have a generation ago to help manage hemorrhage.
Well, you know, and that's a good point that we didn't get into, but direct pressure, that's always my go-to skill as a police officer where it's an accident, stabbing, shooting or whatever. Just put on a glove and put some good pressure, or grab that t-shirt or whatever, 4x4s. We went through a lot of 4x4s, and it generally works pretty good. But have a plan. And if you can, have equipment in place. But as we've talked, there's other things. You were talking about desensitizing yourself. I tell this story, and it's a little unpleasant, but it was the moment. It was one of those times when you really are self-aware and you have almost an epiphany about something. Years ago, when I was a sergeant on the police department, and a person, I don't even remember, male or female, had passed away. And we got the call. The guys went down there. It appeared to be natural causes. House was locked. No knife sticking out of the person. But unfortunately, they hadn't been seen for a while. So natural processes took place, and it was a pretty unpleasant scene. So I stopped down there to make sure my guys needed anything. We take in the report. Coroner's been called, blah, blah, blah. Everything's cool. You guys need anything? Nope. Okay, well, I'm going to go back in service. So I walked out to my car, and it was cold, put it in drive, and I started popping combos, those pretzel things with the filling. I'd been eating them, pulling up the call, and I'm driving away, and I'm just eating and, listening to the radio, and I thought, normal people don't do stuff like that. I was just in this pretty unpleasant scene, and I'm eating pizza combos driving away. I guess I'm a veteran officer at that point. So,
well, and you can't judge cops and ER staff and soldiers based on the same standards that the rest of the world is judged by. If they're making off-color jokes about something that just offends your sensibilities, well, if it's the ER guy or the charge nurse at the emergency room, there's a fair possibility they were neck deep in some horrific something 15 minutes ago. And the amazing bit is that you can leave that in the other room and then walk in and take care of somebody's ear infection without bringing too much of that with you. And so this is only tangentially related, but I have a fundamental aversion to embedded reporters with combat troops. What happens downrange, we don't need to act like animals and hold ourselves to respectable human standards, but at the same time, we don't need to sit in our living rooms and be second guessing what Private Snuffy is doing when he lost his best buddy the day before and the bad guys are trying to kill him.
Yep.
But yeah, there's a lot of what would seem to be terribly off-color humor that you find in law enforcement and in the emergency room that doesn't translate well to the rest of the world, but on a certain degree, on a certain level, it's a coping mechanism.
Exactly.
And if we had a little extra time, I have some poignant stories about the transition from doing that and then coming home to your family. And your family does not deserve that.
Yeah, exactly.
You got to figure out a way to leave that somewhere else because they deserve better than coming home. And, there have been times I'll walk in and my wife will say, "How was your day?" And you just say, "Your day, my day was fine. Thank you. Let's get into yours." Somebody's got to do those jobs.
Yep. And I'm sure you've had the moment where you're just literally hand on the doorknob and you're like, okay, I'm home. That's where I'm at, so you remind yourself.
To be quite honest, I came home one day from the emergency room and we had a dog named Samantha, and Samantha had been, we were a homeschool family, so my kids were there with my wife, and the dog had been distracting, so the dog was in the laundry room, and I walked in, and it's such a sweet, precious golden retriever, and it's just what I needed after a hard day, and I noticed that she wouldn't leave my feet alone, and it's when I realized that my socks were soaked in human blood.
Oh.
And so I took my shoes off and I put them out in the garage, and I took my socks off and I cleaned them out in the sink, and then I walked in and my sweet precious wife said, "How was your day?" And it's just, well, my day was fine. Thank you. You don't say, well, I put my shoes in the garage so the dog wouldn't lick the blood off of them.
Yeah.
She deserves better than that. And, but at the same time, it's got to be done.
Well, Will, thanks for talking about this. I guess it's not really a happy topic, but it's one of those things, my big thing to folks is you don't even want to think about it, but you need to, because we tend to lead active lifestyles. And if we spend time around gun ranges, sometimes bad things happen. And overall, just in your daily life. So I appreciate you coming on and talking about it. And we'll have some more stories one of these days. Maybe we can come up with some fun stuff or something. But I do appreciate your experience, and we certainly appreciate all you do for guns and American Handgunner. You're one of our crowd favorites, so we appreciate you coming on and talking video with us.
I get more out of it than you guys do.
I always enjoy our chats with Will Dabbs, MD, and though today's topic was a little bit dark, or a lot dark, I hope we've given you some things to think about and to file away in case you ever have a dark day in your own life. Before we go, some housekeeping stuff. Of course, make sure you like and subscribe the podcast. I know I sound like a broken record, but that truly is the best way you can support what we're doing here at FMG Pubs and the Guns Magazine podcast. So hit those like and subscribe buttons, and someday we'll have a zillion subscribers, and I'll shut up about it. Also, make sure you check out our great sister publications, American Handgunner Magazine at AmericanHandgunner.com and AmericanCop.com. And oh yeah, by the way, gunsmagazine.com. I think it's a pretty fair magazine. You can check it out online. And if you would like to subscribe to Guns Magazine or American Handgunner, you can do that at fmgpubs.com. That's also where you'll buy our special interest publications like Roy's new Insider book and John Connor's Odd Angry Shot. That's fmgpubs.com. And of course, don't forget our great sponsor, Armasight. Step up your game with Armasight's cutting-edge thermal and night vision monoculars. Built for hunters, tactical pros, and outdoor enthusiasts who demand clarity and reliability in any environment. Discover the performance and durability trusted by hunters and professionals worldwide. Gear up now at Armasight.com. Stop looking, start seeing. Well, that's it for this episode of the Guns Magazine podcast. On behalf of everybody that works here at FMG Publications, I'm Guns Magazine editor Brent Wheat, reminding you for another week, now get out there and get shooting.